2 talks about endocrine. This is going to be quick. One thing, the reason I say it's going to be quick is because we just don't see patients with endocrine disorders. We see where they have something else going on. So you're not going to just see a patient that has hyperthyroid. You're going to see it because they have palpitations, tachycardia. So their causes of that disease might be why they're coming in. Long and short of the story. But thyroid-wise, we have a major role in our thyroid. It controls our cellular metabolic activity. That is the role, of course, with these other, of our thyroid. Just a quick picture to see where it's at. One thing that I want to point out with this is you see the thyroid here, but on the back, we have 2 on each side of our parathyroid. That's important for later discussion, okay? So, diagnostic tests associated with thyroid goiters, cyst, hypothyroidism. So, hypothyroidism. When we're talking about hypo, we're talking more women than men. Here's your signs and symptoms. Early signs, not as specific, but later signs, they get these. Okay? And then, with the myxemia, this can lead into progress into coma, stupor, and death. When it reaches coma, it's 100% mortality rate for these patients with low thyroid function. A lot of times we see that with stress, infection, respiratory failure, heart failure, just to name a few. And it's because it leads to high cholesterol levels. That's why we get heart failure with these patients. Everything slows down. It's a good way to think about hypothyroidism, which you should already be comfortable, because you've probably heard this many in your med surges, and a little bit in pharm. So hypothyroidism is lifelong levofloxacin treatment. Levothyroxine is, what do we call that in pharm? What was the name I gave levothyroxine that should be his first name?
Synthroid.
Huh? You guys are getting way too technical. Yes, the trade name is Synthroid, but what name did I give this medication? Atrol. It needs to be all by itself under the bridge. Do you guys remember the word troll? Yes.
Yeah.
Okay. With the hair sticking up all by himself under a bridge. It gets along with nothing. So my point to this is the interactions are many. So when you have a levothyroxine order for 6 a.m., then you see that the other medications are at 8, probably 9. That doesn't mean you give it all at once. It needs to be given alone because of many interactions. One of the biggest interactions is the anticoagulant of warfarin. It will cause more bleeding for that patient. So, keeping that in mind, one thing about levothyroxine therapy, it also can change the patient into hyperthyroidism. When I think of hyperthyroidism, I think of that bouncy ball going everywhere. They have palpitations, tachycardia, they're just wired. They have the bulging eyes. And again, cardiac dysrhythmias to failure. Goiters. Goiters are also seen with hyperthyroidism. One thing about goiters is they won't do much about it unless it causes the trachea to deviate. And now it's causing respiratory problems. You have to think about the location of where a thyroid is. Again, more women than men, usually ages 20 to 40. Some of the medication that are associated with hypothyroidism is listed there. Then they may choose to do a thyroidectomy. We will talk about that momentarily. Just know with the disease and treatment and a thyroidectomy, it makes them hypothyroid. So we have to be lifelong thyroid medication.
Why the dexamethasone?
It's a steroid for the cortisol. Yeah, it has to do with the cortisol. So, thyroid cancer. We'll get back to thyroidectomies in a bit. Thyroid cancers. So again, who? More women than men. As it grows, that's where the respiratory problems develop. If there is a family history, more prone for thyroid cancer. If there was radiation treatment to the patient 10 or 20 years previously, they're more prone. Now, you know, if you've ever gone into a radioactive, like going to the dentist, you're getting your x-rays done, they always put a thyroid cover, right? Lead apron here, and then any other genitalia, right? And that's protecting. So x-rays can also expose the thyroid to thyroid cancer as a whole. Surgical management, it is very rare. They will do synthroid therapy if it's benign. If they do have a spot and it's benign, they would do synthroid therapy with these patients with thyroid cancer or levothyroxine. Surgical management, they will take the thyroid out. With that said, laryngeal damage can happen with thyroidectomies. Hemorrhage, think about how many vascular vessels are located in that region. Respiratory distress, and then hypoparathyroidism. So what does that mean? That means my calcium is low and my phosphorus is high. So now we're looking at an electrolyte imbalance with these patients. Brittle bones. So safety becomes an issue as well. Post-op care for these thyroidectomies. The biggest thing to remember is one, they should not be talking after thyroidectomies. So you need to establish early on how you're going to communicate with the patient. Should be minimal talking. High talking, it irritates that region and causes inflammation. Now we have airway issues. Okay? So that's first and foremost. The second thing is, that head needs to be supported. It has to be midline, it cannot be tucked to the chin, and it cannot be hyperextended. We don't want to put any strain on that area. So midline means, if I look at the patient from the lateral side, that head is aligned with everything else on that lateral side of that patient. Whether it's support with 2 pillows, elevation of the bed, whatever the case may be, we don't want to cause them chin to chest, and we don't want them to have hyperextension. Again, communicating with them through a communication board, writing it on a paper. These patients will need to be on an ECG monitor because with their drop in the calcium levels, they will need calcium gluconate. We have to administer calcium gluconate on a monitor to watch the QT intervals, okay? And anything else that may show up. These are not patients that should be talking on their cell phones after. I think I've stressed that enough, right? Parathyroid. Huh?
How long would you say they have to be
I mean, it's a rule of, just like any surgery, is 48 to 72 hours. If you see that the inflammation and they can swallow better, then that means the decrease is going down, but I wouldn't let them talk up a storm like I do. You know what I mean? I would have them just rest their voice. Nowadays with cell phones and all that kind of stuff, texting would be the best thing that they can do. And that could be the way that you form to do your discussions with them too. That's up to me. They can hear you, but they could text you what they need.
What about eating and drinking?
It's all assessed if they can swallow. Yep. So if it's a severe case and they had a lot of hemorrhage, they will probably not. They might have to do TPN to rest that area. It depends what has happened during their thyroidectomy. It's a priority right after surgery, because we can give whatever we need to be on IV fluids, plus the calcium gluconate. If it's a good sign that they say they're hungry though, because that means that the pain is minimal, and that swelling has probably gone down because they can swallow better. So that truly is a good question for them to say is, when can I get something to eat? With the parathyroid, we know where it's located. It's behind. And so that is one of the big things with a thyroidectomy is to become hypoparathyroid. So with our parathyroid disease of hyperparathyroid, this is where they get calcifications. Brittle bones too. The brittle bones is from the chalk-ish calcification sitting on the bone as a whole. Usually over the age of 60, more women than men. One thing is we want to hydrate therapy would be a 0.9 normal saline hydration. Lasix would also be promoted because furosemide, Lasix, promotes calcium loss. We would never give a thiazide diuretic because it promotes renal retention of that calcium. So loop diuretics, furosemide would be the best choice, and then no thiazide whatsoever. When they reach this crisis of having too high of calcium and too low of potassium, this is where they have ugly urine. This is where they need emergency surgery to remove that parathyroid. And then they need a hemodialysis of calcium-free and a biphosphate. Once we remove it, and they become hypoparathyroidism.
You said after the hemodialysis for what?
For calcium-free and a biphosphate.
Okay.
Welcome. Once this is removed, then of course they go back and retreat back to the hypoparathyroidism. So what vitamin can I give to help calcium absorption? Vitamin D. So D would be the winner to help with that. In our world of Cushing's, Cushing's takes on a male characteristics. This is a female who takes on, based on Cushing's, that has the buffalo hump, increased facial hair. And so, again, with our patient who has our Cushing's, we will have hyperglycemia and all this other stuff that goes in as a whole for these patients. Keep in mind, you just don't come in because the Cushing's is acting up. They bring it in because of the other symptoms with these patients. So there'd be more than just that as a whole. Assessment, recognizing, and of course, emotional support. Your diagnoses. Then that leads us to the first crisis would be a decrease in the function of adrenal glands. And then we also see adverse reactions of this activity. Renal mets can happen, TB. These are patients that are autoimmune and more susceptible because of Cushing's. More susceptible to any debilitating or autoimmune disorder. Plan and interventions are listed there for you, what the patient needs. Questions about any of that?